Dr. Lisa Anderson, we are very grateful today to have her and to talk to us. She is a consultant cardiologist at St. George's Hospital, heart failure specialist. She will kindly enlighten us today about management of heart failure patient in cardio kidney metabolic clinics. Thank you very much. You can start.
Thank you, Mohammed.
Yeah.
So here at St. George's, we developed our heart failure kidney clinic around the same time as we opened our heart failure unit. And I wasn't absolutely convinced we needed it at the time, because I thought that we were actually treating our CKD heart failure patients quite well. But it's only when we really analysed our data that we saw that they were being undertreated. And since we've had the joint clinic, it's really helped us to push further with the CKD patients. Unfortunately, although they benefit just as much and probably more than heart failure patients without CKD, often they're not fully up-titrated. And this is because of natural cautions like fear of hyperkalemia, fear of worsening renal function. So people will maybe try a little bit but then stop and try medications that they're very familiar with, rather than some of the newer medications which they're a bit more cautious about. And what we've really seen in the cardio-renal clinic is that we can get some of these frailer, elderly, comorbid patients on full dose of heart failure medications really very effectively. And what has surprised me a lot is actually how well we can manage them without causing hyperkalemia in a lot of the cases. The other advantage of the heart failure kidney clinic is that we have access to a renal physician, and we have access to potassium binding agents if, when we're up titrating, we are causing hyperkalemia. So I think normally if you don't have that, you will probably stop early before you get to the point of causing hyperkalemia, whereas we sort of up titrate, and if hyperkalemia occurs, we treat it and maintain the patients on treatment, with the priority of getting patients onto treatment and maintaining them over keeping a normal potassium and not having them on medication. The cardio-renal clinic has other benefits as well. It's a very good way to optimize our patients in terms of fluid balance, and as well as using oral diuretics. We've got projects where we've used subcutaneous diuretics to avoid admission to hospital. And another big priority, I think, is the combined input of a cardiologist into the renal team, particularly in those patients who are being worked up for renal transplant, because it's not unusual for us to find that the patients have impaired ejection fractions, but also quite severe hypertension that hasn't been adequately treated. And when we aggressively treat those patients, we can see the ejection fraction improve, and the patients then become eligible for cardiac transplantation. That's really important for a patient with cardiovascular disease and CKD, because a patient on dialysis is at much higher cardiovascular risk than a patient once they've been transplanted. So moving them from dialysis onto a transplant is very important for their heart as well as their kidneys and for their quality of life.